Well, hello, everyone, and thank you for tuning in. My name is Adam Rule. I'm an assistant professor at the University of Wisconsin-Madison's Information School, and today it's my pleasure to present some work that I've done with colleagues at Oregon Health and Science University, looking at the impact of medical scribes on clinical documentation. So we know from prior literature that employing scribes can boost clinic efficiency and reduce documentation time. But there's also been some follow-up qualitative work that's shown that scribes may have a variable impact. That is, they may not have the same efficiency gains from working with scribes for different physicians, and there may be more or less effective and safe ways of working with scribes. But up to this point, what scribes document and how their presence in the clinic workflow affects the documentation workflow of other members in the clinic really hasn't been described in detail. So our research question in the study was to begin to ask, what do scribes actually document in the record? And how does what they document affect existing documentation workflows of other members of the care team? In order to do this, we picked a specific setting for this study. In this case, the Ophthalmology Department, or KCI Institute at Oregon Health and Science University, which is a large academic medical center in Portland, Oregon. That department, the Institute, has over 50 physicians who perform over 100,000 outpatient encounters each year. And they use a particular module within our electronic health record, EPIC, to document patient care. And this module, Kaleidoscope, includes some features specific to ophthalmology, like ways of tracking visual acuity. Another unique thing about this setting, and one of the reasons why we chose it, is there are already other team members involved in patient care and in documenting patient care, specifically ophthalmic technicians. These are individuals who have specific training or an associate's degree in performing routine eye exams, and they usually room the patient, are among the first clinical staff to see the patient, perform eye exams, and then start documentation, for example, starting the note. The scribes in this context would assist with documentation during the patient interview and the physician's exam with the patient. So a typical workflow would be patient comes in, sees the technician leaves, and a provider comes in with the scribe, does the exam while the scribe is documenting, and then later the attending physician, the provider, might wrap up documentation. As for participants, we worked with collecting data on 7 attending physicians who worked with scribes on some days and not others, so we could get a comparison of their documentation on days that they worked with the scribe and on days that they didn't. Those attending physicians worked with 6 different scribes, one of whom was a pre-medical student, and 5 who were ophthalmic technicians who had transitioned over to providing scribing services. And then there were 58 different ophthalmic technicians who worked with these teams. Just to show how these individuals work together, focusing on physicians and scribes, there were 2 physicians, who I'll refer to as physicians 1 and 2 throughout the rest of the talk, who worked with the same scribe, in this case, that pre-medical student. A 3rd physician had a dedicated scribe, and then the other 4 had a team of 4 different scribes who they rotated through working with, depending on availability and scheduling. As for data collection, we started by looking at all outpatient visits conducted in 2018 for these 7 study providers who typically worked with scribes. There were about 22,500 of those visits, only 13,000 of which we included in the study because we excluded pre- and post-operative visits and visits with a trainee like a fellow or a resident present, as that may change the workflow rather dramatically. We then got the EHR audit logs for these visits. And I have a reference here for those wanting some more background, but in essence, audit logs are logs that track interactions with the EHR. What I'm showing here is a graphic representation of what one of those logs might look like. And these horizontal gray bars are each a different patient that a provider might be interacting with that patient's record. And the vertical bars throughout are showing discrete events where the provider interacted with the record. The 3 different shades of gray here are for different types or categories of activity. So darkest maybe being reviewing the patient's record, slightly lighter is ordering activities, and the lightest still documentation. So you can see a pattern of a provider maybe pre-rounding on the patients in the morning and then having their encounters with them later in the day and some follow-up activity later in the evening. And each of these bars really represents a row in a table that has information like what time this event occurred, who performed the event, what medical record it was done on, what the event was, in this case, viewing the patient's problem list for the event I'm showing with the arrow, and then maybe the ID of the computer that came on. Now, what this data lets us do is answer a certain set of questions. So one, looking at what is it that each individual edited? So the technician, the scribe, or the provider in the care team, what did they do to edit the record? Two, looking at when they made those edits over the course of the day, especially relative to the start of the patient encounter. And then how long in total, if we're to sum up all of the time interacting with the record for each of these individuals, how does working with the scribe affect overall documentation time? Kind of as a sanity check against this recurring finding that working with scribes can reduce the physician's documentation time. As for findings, we found that working with scribes had a variable impact on who documents what. And I'm going to show you a more complex figure here in a minute. I wanted to start with kind of this one section of it that we'll show in multiple in a second for each of the providers. What I'm showing here is a representation of how working with a scribe changed who did what activity. So this is data for provider one, who worked with scribe one, this pre-medical student. And what I have in these columns is the actions or frequency of how often these different roles would perform in action. So on the x-axis is the percent of encounters where each of these three individuals performed that activity. And on the y-axis is an activity that we saw a lot of change, or that the scribe did fairly often. So if we focus in on the scribe section here, these blue dots represent how often the scribe did something in non-scribe visits. So whether it was pending the note, modifying diagnoses, all the way down to updating the diagnosis association, all the blue dots are at 0, because if the scribe wasn't present in that encounter, they wouldn't be doing anything to edit the record. Now for scribe visits, visits where the scribe was involved in the encounter, those are the orange dots here. And so we see in almost every single encounter, scribes are helping to edit the note, modifying patient diagnoses, saving information on their exam, and only, in this case, about 20% of the time, updating a diagnosis association. Working with a scribe also had an impact both on technicians, what they did, and how often in the provider. Starting with technicians, we see some shift where certain activities, like how often they would modify the visit diagnosis, they're doing this less often or in fewer encounters. Although this is dwarfed by the change that we see with providers, where they're going from modifying diagnoses and exam information and problem lists in the majority of visits to the minority of visits, this big shift that you see by this gray bar. Now, to show the variable impact of scribes, I want to show the same representation, but in this case for all 7 providers. I have these kind of gray outline boxes around providers working with the same set of scribes, the first scribe, the second, and then the battery of 4 scribes here, scribes 3 through 6. And if you focus first on just what the scribe does for scribe 1 working with providers 1 and 2, we see this pattern where the scribe in almost every visit does the same set of either 5 actions with provider 1 or 3 actions with provider 2, mostly editing the note and exam information, and they rarely do anything else. When we look at the scribes working with the other providers, scribes who had been trained as ophthalmic technicians, we see more of a pyramidal pattern. Yes, they're editing the note in nearly every single visit and say the exam information, but there's this long tail of other activities that they're involved with in some encounters and not others. And these involve things like modifying the diagnoses, modifying vitals, or updating the order list. So other aspects of clinical care beyond just documentation and prepping orders or taking down vital signs that you might expect someone else on the care team to do. Our second thing was looking not only what was done and how what was done shifted between different individuals, but how introducing a scribe into your team changed when documentation was done. What I'm showing here is a histogram of the edits for provider 1, essentially saying when they edit the patient record, when are they doing that relative to the start of the patient encounter? And I have 2 overlapping histograms. And the blue is for visits without a scribe present, and orange for visits with the scribe present. So focusing on blue, we see this kind of median of action happening about an hour after the patient visit. And that shifts a little bit to the right to maybe an hour and a half after the visit and scribe visits. So we see the shift in providers editing the record later when working with a scribe, or at least provider one is. What's interesting is there's variation amongst the providers, and I won't show all 7 here. I'll just highlight provider 2, an individual who worked with the same scribe as provider 1, yet we see a very different pattern where when they start working with that scribe, they shift their editing to much later in the day. You see this very flattened out curve all the way out to 12 hours after the patient encounter or more. Digging into this, we found that this provider seemed to be batching when they edited the patient record. They do some things right after the visit, but wait till later in the day to finish wrapping up that record. So again, this impact on when documentation done that varies by providers. Lastly, we saw a variable impact on how long different providers spent documenting. So on the right here, I have on the x-axis, the different providers, so our 7 different providers, the y-axis, the amount of time they spent documenting in the EHR per patient encounter. The blue bar is that time for visits without a scribe present, and the orange bar for visits with a scribe present. And then the asterisk is showing whether there was a significant difference between those 2 types of visit. In every case, providers saw a significant decrease in their documentation time. Though it's interesting to note some providers, say again, comparing provider 1 and 2, saw very drastic changes. So provider 1 dropped a little bit, maybe about a minute to a minute and a half less per visit, whereas provider 2 saw a large drop of about 5 minutes fewer per visit. Beyond this, we also noticed that there was an impact on technician documentation time. So on the left, I'm showing a very similar graph, but now showing the amount of time that the technician spent documenting in the patient record. And what I've highlighted here in red is 2 examples where technicians actually spent slightly longer documenting when working with the scribe. Only one of these cases for provider 1 was that significant, and for providers 3 through 7, we actually see a decrease. But it is interesting to note there are some cases where potentially introducing a scribe into your team reduces the documentation burden of the clinician, but maybe not of support staff like the technician in this case. So what do we do with this data? First, I want to note that we saw similarities across all scribes in what they did to edit the record. Namely, they edited the notes, the exam findings and diagnoses, but we also saw some trends where some of those scribes also edited things like vital signs and the orders. We also saw that working with a scribe would shift when physicians documented, and sometimes rather dramatically to much later in the day, though that depended by physician. And lastly, while scribes universally, in this case, reduce clinician documentation time, and that aligns with prior findings in this area, there are some cases where it seems like they might actually increase documentation burden for other members of the care team, in this case, ophthalmic technicians. Overall, more research needs to be done to examine the influence of different models of scribe training and scope of practice. We had 1 scribe in here who was a pre-medical student, so had very little prior clinical training, several who actually had some clinical training. And while we saw differences between the 2, it's hard to tease that out with such a small N. And also there's some questions about might providers benefit from training on how to work with scribes? And looking at why is it that some providers working with scribes saw a massive drop in their documentation time, while other providers who worked with the exact same scribe didn't see as bigger reductions. Now, before we wrap up, I just want to note some very clear limitations of this work, which is very preliminary. 1, we have a small sample size, only 7 providers and 6 scribes. And while that let us do this kind of detailed analysis of what everyone was editing, need to look at more data to get generalizability. Second, it was a single outpatient specialty studied at 1 institution. There were some unique aspects of that specialties that were appealing for this study. 1, that there are already other individuals involved with documentation. So we got to see how adding a scribe to an already collaborative documentation workflow influenced that workflow. But it also has its own unique aspects that may not generalize to other specialties. We only looked at EHR editing and not reviewing of the EHR, and so could see different patterns there. And as we compare different scribe training models, say those who have prior clinical training versus those who don't, we only had one pre-medical scribe in this study. So any differences we observe there may just be due to differences in individuals and not truly causal by their training. As I wrap up, I want to acknowledge my co-authors, Dr. Michelle Rybar at Oregon Health and Science University and Dr. Michael Chang, now at the National Eye Institute. I thank the Ophthalmic Informatics Lab and Department of Medical Informatics and Clinical Epidemiology at Oregon Health and Science University, and my current institution, the Information School at the UW-Madison, for all of their support in this work. This work was supported by a number of grants listed here, both from the NIH and from Research to Prevent Blindness. And some discussion of the methods used in this work was published at AMIA 2020. So I direct you to that work if you're interested in it. Thank you so much for listening. I look forward to any discussion that comes out of this. You can contact me at the email listed here.